Hello, myself Dr. Prashant Patil. I am consultant radiologist at Patil Diagnostic Center, Dhule. I am presenting paper on the topic ultrasound findings in Caesarean scar pregnancy, a three-case pictorial review. So Caesarean scar pregnancy occurs when GSAC implants into the myometrial defect at the site of previous Caesarean delivery, and its prompt diagnosis is essential to reduce the risk of severe hemorrhage, uterine rupture, and maternal morbidity. This pictorial review demonstrates the imaging findings from three CSP cases. The study is retrospective review of three CSP cases evaluated by transvaginal and transabdominal ultrasound, and all examinations were performed on Samsung V7 ultrasound system. We classified the cases based on the classification system by Jordan et al. In this system, they classified CSP into three types. In for type 1, the largest part of GSAC crosses the uterine cavity line, and most of the sac is located within the endometrium. In type 2, the largest part of GSAC is embedded into the myometrium, and in type 3, the GSAC crosses the serosal line of the uterus. This is the case 1. She is 37-year-old woman with prior two cesarean deliveries, comes at 7 weeks, 4 days gestational age. This is her first ultrasound scan, and she has no complaints. On transabdominal scan, we can see the GSAC in the lower part of uterus. GSAC appears to be slightly bulging anteriorly with thinning of the overlying myometrium, and upper part of endometrium appears empty as seen here. So we did the TVS, and TVS confirms the location of sac in lower part of uterus just superior to internal os. Then a single viable embryo with the CRL 21.3 millimeter, which correspond with 8 weeks 5 days gestational age, is seen within this sac. The yolk sac is very well seen. Cardiac activity is also visualized with the heart rate of 173 beats per minute. Then GSAC appears to be slightly bulging anteriorly with significant thinning of overlying myometrium, and residual myometrium thickness, that is RMT, measures 2.5 millimeter at present. This TVS video demonstrated the low position of GSAC, which is situated just superior to internal os. Then there is empty upper endometrium and very thin anterior myometrium. So for classification purpose, we draw these lines, and we can see that GSAC is seen slightly crossing the serosal line of uterus. There also we can see the GSAC is crossing the serosal line of uterus. So we diagnosed it as a type 3 cesarean scar pregnancy. This patient undergoes the operative management by combined laparoscopy and hysteroscopic approach, and she was operated successfully. Then this case highlights the importance of early accurate diagnosis of cesarean scar pregnancy with early management preventing any further complications. Let's go to case number 2. She is 34-year-old woman with prior history of one cesarean delivery, and she comes at 9 weeks 1 day gestational age. She is having history of bleeding PV since 2 days. On transabdominal scan, we can see an irregular sac-like structure in the lower part of uterus. Upper endometrium is empty. So we did the TVS, and TVS shows the uterus retroflex uterus, and irregular gestational sac is seen in the lower part of uterus. A good peritropoplastic flow is seen. There is a mild thinning of anterior myometrium with RMT of 6 millimeter. However, blood flow is seen in this residual myometrium, and upper part of endometrium appears empty, as seen here. Also, the lower part of GSAC is seen in continuation with cervical canal. So this video of TVS scan, we can see the sac in the lower endometrium. Then upper endometrium is empty. There is a thinning of anterior myometrium and few prominent lakes or vascular channels. They are seen in the anterior myometrium. So for classification purpose, we draw this line, and most of the sac is seen crossing the uterine cavity line. So we classify this as a type 1 cesarean scar pregnancy. As overlying myometrium thickness is good and the lower part of the sac is seen in continuation with cervical canal, treating obstetrician at periphery decided to do DNC, but just after starting the procedure, patient developed a significant PV bleeding with passage of clots. So they abort the procedure and send the patient for follow-up ultrasound on next day. Meanwhile, patient also diagnosed as a thalassemia minor patient, and her post-procedure HB comes down to 7 milligram per DL. Then on follow-up scan, we can see an ill-defined heterogeneous area in the lower endometrium. This area appears to be extending into the anterior myometrium with good surrounding flow. So on TVS, the ill-defined heterogeneous hypo and hyperechoic area is seen in lower endometrium and upper part of cervical canal. A good surrounding flow is seen, and there is a thinning of anterior myometrium. The anterior myometrial thickness, that is RMT, measures 4.3 millimeter at present, and this heterogeneous area is seen extending into the cervical canal. So these videos of transvaginal as well as transabdominal scan show heterogeneous area in the lower endometrium, which extend into the anterior myometrium. There is a good surrounding peritropoplastic flow, and upper endometrium is empty. So from these findings, we diagnose this patient as the case of written product of conception in caesarean scar pregnancy with extension of these contents into the myometrium. Patient was referred to higher center. At higher center, she was operated by combined laparoscopic and hysteroscopic guidance, and patient was operated successfully and she recovered. So this case highlights the importance of deciding the proper management protocol for caesarean scar pregnancy patient. Now let's go to case 3. She is 30-year-old woman with previous 2 cesarean deliveries, come as 7 weeks 0 days gestational age by LMP. On transabdominal scan, uterus is seen significantly retroflex. GSAC is seen in lower part of uterus just superior to internal os. In we did the TVS. On TVS, a well-defined GSAC is seen in the lower part of uterus. The upper endometrium appears empty. GSAC is located just superior to the cervix. And a single viable embryo with the CRL of 7.82 mm corresponding with 6 weeks 5 days is seen within the gestational sac. Cardiac activity is visualized and heart rate is 115 beats per minute. There is significant thinning of overlying myometrium. The RMT measures just 2.1 millimeter at present. This video of TVS demonstrates the low-lying sac with empty upper endometrium, and there is a significant thinning of the overlying anterior myometrium. So for classification purpose, we draw these lines and we can see that most of the sac is seen embedded into the myometrium. So we classify this as type 2 caesarean scar pregnancy. This patient undergoes the operative management by combined laparoscopic and hysteroscopic approach. The most of the product of conception and GSAC embryo, they are evacuated by laparoscopic approach, but small gestational tissue is also removed by the hysteroscopic approach. So this case highlights the importance of early diagnosis of caesarean scar pregnancy and shows the usefulness of combined laparoscopic and hysteroscopic approach for management of caesarean scar pregnancy. So these 3 cases illustrate the variability of CSP presentation. Case 1 and 3 highlight the viable caesarean scar pregnancy. Case 2 demonstrates the non-viable CSP. Then according to Jordan classification, case 1 is type 3, case 2 is type 1, and case 3 is type 2 caesarean scar pregnancy. And in all cases, TVS identify the all key diagnostic features. And in all our cases, the uterus's retroflex is also an important risk factor for caesarean scar pregnancy. So we can conclude that ultrasound plays a vital role in early detection of caesarean scar pregnancy. Thorough detailed imaging assessment include the sac location, myometrial thickness, and Doppler vascularity. We can promptly diagnose the caesarean scar pregnancy and guide the patient management. The presented cases underscore the importance of systematic ultrasound evaluation in patients with prior caesarean deliveries. So these are my references. Thank you so much for the listening.